Researchers have identified 3 possible mechanisms that trigger cancerous growth in cells, and the most common hypotheses point to cellular DNA damage as the main culprit. This results in cells that have altered DNA, and hence, altered properties and have the potential to grow at a higher rate. Different factors such as excessive exposure to certain chemicals such as steroids or chemicals in asbestos, exposure to high doses of radiation or hormonal stress have been explained as the cause of the change in DNA composition. These factors can result in activation or expression of growth-inducing oncogenes, alterations of genes that regulate apoptosis, programmed cell death, or inactivate tumor suppressor genes. Since the 20th century, treatment options for malignant tumors have broadened from surgery, surgical removal of tumors, to chemodrugtherapy, use of anticancer drugs, often intravenously, to kill cancerous cells or reduce symptoms, and radiotherapy, application of gamma radiation to affective areas to destroy tumor cells, and in some cases, all 3 of these options are combined. The term chemotherapy was used as early as the first decade of the 20th century by the renowned microbiologist and physician, Paul Ehrlich. Originally an antimicrobial procedure, chemodrugtherapy is now widely used to treat cancers. Chemotherapy for cancer treatment was carried out in the 1940s when some patients suffering from lymphoma were intravenously given sulfur mustard to observe its effect on their white blood cell count. The patients showed temporary recovery, which was considered a breakthrough, and this promoted researchers to look for new chemical agents. Mustine mechlorethamine was subsequently discovered in 1942. It is also worth mentioning that cancer chemodrugtherapy can involve a combination of drugs, a cocktail of drugs. The original purpose of chemotherapy was to kill cancer cells through the use of cytotoxic drugs. This is called classical chemotherapy. Non-classical chemotherapy involves the use of antibodies that bind to specific proteins or biochemical factors that are either expressed by tumor cells or essential to their growth, or both. This article will summarize the types of drugs used in chemotherapy, chemodrugs or anticancer drugs. Such drugs can be classified on the basis of chemical structure, action, or on the basis of biological role, function. We will use the most commonly recognized categories, based on both properties. Alkylating agents. The first class of anticancer drugs to be discovered was alkylating compounds, which have the ability to add alkyl groups to DNA and RNA strands. Alkylated strands tend to break during processes of DNA repair and eventually trigger apoptosis. Therefore, these drugs are inherently cytotoxic in nature. Alkylating agents are also not cell cycle specific, i.e., they will kill both dividing cells and resting cells. Because of these properties, alkylating agents have severe side effects including emesis, suppression of bone marrow growth, alopecia, hair loss, and reduced gonadal activity. Long-term use can result in permanent infertility, and in rare cases, acute leukemia can also occur. Examples of alkylating agents include cyclophosphamide, Cytoxan, chlorambucil, leucerin, and busulfan, mylurin. Some alkylating agents are neutrosorias, such as streptozocin, and these are useful for treating brain tumors as they can cross the blood-brain barrier. These drugs have to be administered in controlled doses, as high doses result in a lot of cells, both normal and abnormal, dying. Some newer alkylating agents are also useful for treating cancers that resist other alkylating agents such as altretamine, which is used to treat alkylation-resistant ovarian cancer. Antimetabolites. This class of chemodrugs is normally comprised of structural analogues of metabolic products of cancer cells and relies on increased susceptibility of such cells to its actions. Most antimetabolites interfere with normal metabolite synthesis, including nucleic acid synthesis (DNA) or nucleotide synthesis. Antimetabolites have been successfully used to combat many types of cancers including leukemias, carcinomas, and sarcomas. One of the most well-known antimetabolites includes methotrexate, a folic acid antagonist which acts on dihydrofolate reductase. Methotrexate, however, does have dermatologic and gastrointestinal (GI) side effects. Other init metabolites include pyrimidine and purine antagonists such as thiopurines and fluorouracil. These compounds are, however, capable of severe myelosuppression, in addition to GI and neurotoxic effects. Antibiotics. Antibiotic chemotherapy drugs are derived from species of the bacterium Streptomyces. These compounds normally inhibit DNA synthesis by intercalation between DNA base pairs. These can be broadly divided into two categories: anthracyclines and small peptides. Clinically significant anthracyclines include doxorubicin and daunorubicin, which are topoisomerase inhibitors. These have been used effectively in chemotherapy for several types of cancers. Doxorubicin is preferred in solid tumors such as those found in carcinomas of the breast, uterus, lung, gonads and thyroid glands. It is also useful as an adjuvant chemotherapeutic agent in osteosarcoma and rhabdomyosarcoma. Daunorubicin is more effective in hematological cancers. The most dangerous side effect of this class of drugs is potentially irreversible cardiotoxicity, and therefore, physicians need to carefully monitor cardiac activity of patients who are administered these drugs. Short peptides include bleomycin, which binds to DNA, producing single and double strand breaks, which results in free radical formation. This is very commonly used in the treatment of testicular cancer as well as a supportive treatment for lymphomas. This drug can cause anaphylaxis in susceptible patients, so it should be administered only after testing for a hypersensitivity reaction. Bleomycin is not very myelosuppressive in nature. Hormonal compounds. Hormonal compounds compete with sex hormones and therefore, reduce the effects of these hormones, which is believed to control breast cancer in women, and prostate cancer in men. Mechanisms of action include selective estrogen receptor modulation or downregulation with tamoxifen and fulvestrant, aromatase inhibition with letrozole and anastrozole, androgen receptor antagonists, flutamide, and gonadotropin-releasing hormone (GnRH) agonists, leuprolide and goserelin. Most hormonal drugs cause edema, nausea and vomiting as side effects. Drugs such as tamoxifen and fulvestrant have been clinically proven to have comparatively less side effects than most other treatments, with good progress after treatment. These drugs are used in cytoplasmic estrogen receptor-positive breast cancer. In the case of prostate cancer, drugs such as flutamide and lupride reduce the production of androgens and therefore halt the growth of cells in prostate carcinomas. Leuprolide and goserelin have the same effect but do so by inhibiting the effect of GnRH. They have lesser side effects but are more costly, especially at early phase of treatment. Aromatase inhibitors generally inhibit the production of estrogens and are administered in situations where metastatic breast cancer patients do not respond to tamoxifen. They have more severe side effects. Targeted drugs. These anti-cancer drugs are also known as non-classical drugs, as they target specific compounds in specific molecular signaling pathways. The net effect is the inhibition of signaling cascades that may trigger angiogenesis. These drugs can be monoclonal antibodies, tyrosine kinase inhibitors and proteasome inhibitors. Monoclonal antibodies include whole monoclonal antibodies bevacizumab, an angiogenesis inhibitor, and chimera proteins rituximab. Used in the treatment of disorders with increased B-cell production, tyrosine kinase inhibitors include imatinib and nilotinib, as well as geftinib and erlotinib, EGFR inhibitors used in the treatment of specific lung cancers. Bortezomib is a well-known proteasome inhibitor which has been approved by the FDA in the treatment of multiple myeloma. Some of these drugs can treat a wide variety of cancers, but many are still undergoing clinical trials in various phases. Alkaloids. The last class of anti-cancer drugs includes alkaloids, another type of naturally occurring compound, or natural plant product. These compounds contain nitrogen and also have great chemical structural diversity. In terms of anti-cancer activity, we can classify alkaloids into the following groups. Vinca alkaloids. Many anti-cancer alkaloids have been derived from the vinca plant, Madagascar periwinkle. These include vinblastine and vincristine, which disrupt the M phase in cell division by breaking microtubules. These have some side effects, which include bone marrow suppression as well as neurotoxic effects. Podophyllitoxins. Derived from the roots of Podophyllum rhizomes, these block the S and G2 phases of cell division by inhibiting topoisomerase II. These have been used in chemotherapy of lymphomas and genital tumors. Camptothecins. Derived from a Chinese plant, Camptotheca acuminata. Topotecan and erinotecan are two well-known camptothecins. These inhibit topoisomerase I and this ends up cutting single-stranded DNA. These agents can cause anemic symptoms in patients. Taxanes, isolated from the Pacific yew tree Taxus brevifolia. These compounds also block the M phase of cell division and have a wide chemotherapeutic application, for instance, in advanced breast cancer, ovarian cancer, esophageal cancer and gastric cancer. Examples of these compounds are paclitaxel and docetaxel. Because these substances are not water-soluble, they presented difficulties in drug formulation.